Welcome to Racing Heart, a podcast presented by the National Centre for Sports Cardiology, a centre that specialises in an athlete's most important tool, their heart. A quick reminder before we get into this episode that the views expressed in this podcast are designed to be general in nature and should not be used to substitute for personal medical assessment. If you have symptoms or concerns, please consult your doctor. In today's episode, we've got Bruce Carter, who talks through his journey of heart disease. And of course, we've got Dr. Andre La Gerche there to run us through the science behind heart disease and what we know through as we talk through Bruce's journey. A big thanks to Bruce for sharing this story and the important messages that do come out of it. I hope you enjoy this episode and thanks for tuning in. Welcome, Andre. Welcome, Bruce, to the podcast. The National Sports Centre for Sports Cardiology podcast. Welcome, Bruce.
Thank you, Alex.
Today we're going to chat about Bruce's experience with his previous heart attacks and heart disease, and then get Andre's take on where everything's at, why this happened to Bruce, and the kind of research that's out there today. But first of all, Bruce, can you just talk to us about what your life was like 2015, 2016? 2017. What were you doing? What was going on?
I was director of a company that I had founded with a few partners in early 2000. I was working reasonably but not excessively, and cycling a lot. Having a young son that was a mad keen cyclist and wanting to pursue it potentially as a long-term career. I was out most weekends training with him, and I was probably most weeks upwards of probably 400 to 450k plus, and a lot of it was probably pretty high intensity as well. And I was feeling good. Life was good.
So you were training a lot. You're obviously healthy.
I was healthy. Look, I'm a bit lighter these days than I was, but I was healthy. I didn't smoke. I was eating well. I was at a normal weight. I was not overly stressed. I exercised regularly. I sleep well. I ticked all the boxes. So if you're rating me, out of 10 as a healthy lifestyle, I might have got an 8.5. You get a 10, do you?
Can you give someone a 10?
I reckon you can. I would have thought your description there, you're pretty close to a 10.
Yeah, I like 8.5. Yeah. There's never a perfect score.
And then what happened in 2017?
I still remember the day. It was September 23, 2017. So it was beginning of the school holidays. So Mackie was wanting to go and do a long ride. It was a hot day. I even remember that. And we were going to go and do a sort of 110k hill loop sort of around the northern suburbs back home again. So we left home from Hawthorn, and about halfway around Kew Boulevard, I had sort of this intense indigestion pain, and I just not buckled over with pain, but it was really uncomfortable, and said to Mackie at the time, look, I've just got to slow down. I've got really bad indigestion. I'll take it easy. And I struggled around that ride. In fact, we cut it short in the end. So it was probably meant to be 110. We might have done 90k. And I was just exhausted. Came home, sort of collapsed on the couch, and sort of after that didn't think much about it.
Was that normal to be that exhausted after a...
No, it definitely wasn't. And look, it was a pain. I mean, you've probably experienced it yourself. You've had breakfast, you go out and exercise hard, you sort of get that acute indigestion pain. And I had it before, probably 5 years earlier, when I was using a drink supplement that had a high magnesium level. So it was not something that I had thought I hadn't experienced before. But that to me, that was the day that things changed.
And then what happened after that?
I continued to struggle. I had, every time I went and rode, I'd felt sort of just tired. This pain had come back again. I started modifying my diet, thinking it was a dietary related issue. I went and saw my GP, and my GP gave me some, Somax, to try to help relieve gastric reflux. I was scheduled for just a colonoscopy, saying I was in my 50s, and he thought it was probably, just precautionary if I had a gastroscopy, if I pronounced that right. At the same time, all of which came back clear, and I continued to have pain. So I was at home, not in the office, so I went and saw an alternate GP. He asked me all the usual questions, gave me a different drug for reflux, but thought I should go and have, blood test and a at-rest ECG, which I went and did, and all of that came back quite normal. But, I as I keep describing to people, I just felt as though I'd had a few spark plugs pulled out. I couldn't get energy, I was still trying to do efforts unsuccessfully. McKay's had dropped off from sort of 450 down to 350. And, looking back at my training file now, it was just sort of a downhill trajectory. And, all the time I was writing it off as a more of a digestive issue than anything else. More on the basis that, I had this probably typical view of what heart disease was and who had heart disease, and I didn't ever consider that I would be a potential candidate or be at risk. As Andre was saying, he thought maybe I'd give myself 8.5, not a 10, but coronary artery disease and heart attacks was something that people who were older, overweight, didn't exercise regularly, smoked, and generally had an unhealthy lifestyle. So I didn't, at any point in time, put myself in that category. And if I had, maybe I would have been more proactive in following up with my doctors and maybe trying to direct them a little bit more than I had been.
But if you've been two health professionals, and the two doctors, they both said, no, it's all good, I've got this drug for you.
Yeah.
You're probably in your right mind to think, oh yeah,
it's right. It's okay.
Keep
going.
Why would they not consider that, Andre?
I mean, the problem is that everything's easy in retrospect, and I can't say that if I was in the chair I would have got it right. But having said that, on the other hand, when you're a heart specialist, you see things at the end of the chain, and I call that sort of situation the Iron Man syndrome, because I see it a lot, which is that the younger person who's really fit and well can present with, because your symptoms actually are absolutely classical for heart disease, that I've lost 2 cylinders, I feel fine when I'm at rest, as soon as I go up a hill I've got this indigestion pain. I mean, that if you were 20 kilograms heavier and had a red face and blah blah blah, people would have thought, heart disease. Yeah. But the problem is, and I tell people this all the time, is that the expression, people will be standing on the tram and they'll say, geez, that guy's a heart attack waiting to happen. We're so bad at that. We're not good at the stereotype that we've put as the heart attack waiting to happen is so far from correct, especially looking at people. And then even when we do all of the risk stratification with blood pressure and cholesterol and things, we're better at picking heart disease risk, but we're still far from perfect. And the way that we do risk scores, we can identify people who are at high risk. So age, as you pointed out, people with high cholesterol, high blood pressure, smokers, etc. But they actually represent a minority of the population. So the majority of heart attacks occur in people who are low to low moderate risk. So we do need to, and it's a good message for athletes, because without being too alarmist, I don't want people sort of out there riding and petrified, but young people and middle-aged people who consider themselves immune from heart attacks are, one, not immune, and two, if they get new symptoms, they really need to be checked out. You were in the difficult because you did everything right. You went and you were checked out, but it's a message that I'm trying to push across to medical practitioners all the time as well, because I just so often see this syndrome of people who I'm sure in another context would have been seen, heart disease would have been higher on the list. But, to look at you, Bruce, you would say you're the absolute picture of health. And from what I understand, if we'd done more tests, we still would have said you're the picture of health. But unfortunately, heart disease is common.
And at the time, I thought, I was a unicorn, unique. 2 years later, I couldn't have been more wrong. The number of, the more you tell your story, the more, you realise that a lot of people, have been in my situation, and not all of them get this opportunity to be around and tell their story. The numbers are, as you probably know, just awful as far as the survival rate. But you made the comment about, the Ironman syndrome, and I in some ways, I in the 20s, was a triathlete and did several Ironmans, and continued to ride. And I think you develop this athlete mentality that if it hurts, you push harder. And that's the way that I saw that pain. It was just something that I had to manage. It was not unusual. Pain is just something that you experience every day when you exercise. It's a pain to manage, not a pain to be concerned about.
And also in athletes, it's interesting because some of the people, like where you can look back retrospectively and then know what the pain was, often that pain in some people feels like the extremes of what they do with exercise. It's almost like it's coming on a bit earlier. Yours was more a classical pain. Some people get this shortness of breath and tightness, which is not that different from what people would have when they're absolutely at the limit anyway. Yeah. But it's coming on earlier, and they're thinking, what's going on here? I'm unfit. Yeah. But why am I unfit? So it's interesting in athletes. I used to think that athletes would be hypersensitive at identifying symptoms, but it's much more the other way, where exactly as you just said, athletes are so used to dealing with pain and sort of working their way through excuses, if that makes sense. Yes. And so it's more frequent that you're in this situation where like an example, there was a patient I saw who arrested at the finish line of the marathon, and then in retrospect, I said, did you have any chest pain? He said, yeah, every time I was running, I was getting this, but I just thought I'd get it checked out after the marathon. So people are used to dealing with a bit of leg pain or a bit of whatever, and they sometimes just see this as one to work through, and that's got to be a key message here. Don't work through that one.
Yeah, and I think, I'm guilty of it as well. The mental process is, I don't want to have something wrong with me that prevents me from continuing to do what I do. Yep. Because you get into this routine, you're used to the endorphins every day. You don't want that routine to be disrupted, and you don't want your program to be thrown out as a result of having an illness that prevents you from continuing to do it. And I think, there is then this, mental process you go through that rules out anything that might be serious, and you just come back to the point saying it's all right, I'll just work through
it. More importantly, we've got some coffees here.
Oh.
So from this point, Bruce, when you started to struggle out training, started to get this pain, you're going to see these GPs, how long was it till you had your first heart attack?
Can I just, I've had one heart attack and one cardiac arrest, all in sequence, and I had further issues, but we'll get to that following that event. So 23rd of September 2017 was when I distinctly remember having symptoms, and they just came on. It was just like somebody turned the switch. I don't know why that's the case. And it was on the night of the 30th of November. I'd ridden that day, which I think I went back and looked at my file, and I'd sort of done 40 or 50k, that afternoon. Sarah went out for dinner, so I was home alone, and I went to bed about 11 o'clock, maybe 10:30. I think Sarah just got home. I was stuffed as usual. Was the case at that stage. Went to bed, and 3 days later, woke up in a white gown.
3 days
in ICU at the Alfred Hospital. I have the only thing that I know about what happened on that night was from talking to the paramedics and Sarah and Mackie. So I have zero recollection of the event. But from what I understand, I was, Sarah woke up because she thought I was having a bad dream, was sort of groaning. She tried to roll me over and realised I was just more of a dead weight. Turned on the light, which is about 1 o'clock in the morning. Turned on the light and sort of thought, something was seriously wrong, and called 000. So that was, the beginning of a, very traumatic process for them.
What was happening at that point?
So basically, Bruce, with these narrowings in the arteries to the heart, sometimes when the heart doesn't get enough blood flow, it can become irritable, from an electrical point of view. And so what happened on that night was most likely that one of the arteries actually blocked. So that's what we refer. The term heart attack gets a bit confused here, but the most common use of heart attack is when there's a blockage of one of the arteries, and that stops blood flow getting to the heart, or to part of the heart. And then what happened is what we call a cardiac arrest, where the heart, as a consequence of not having enough blood flow, went into a very rapid heart rhythm, and then basically went into a complete, what we call ventricular fibrillation, where it's doing no meaningful activity at all. So, but people say that the heart stopped. It's more like the heart went berserk.
Went haywire.
Yeah, went haywire. And at that point, essentially, Bruce died, and it was a matter of him being resuscitated or wouldn't be around.
And I did after that look up Kerry Packer's quote from when he was resuscitated following his cardiac arrest, and I can vouch for the fact that there was nothing there.
Right.
I learned a new term when I was moved to the cardiac ward after I'd been discharged from the ICU, and it was called downtime. Not downtown, but downtime.
Yep.
The cardiac nurse came along and was looking at my chart and said, "Oh, wow, you're lucky. You had 35 minutes of downtime." And I said, "What's downtime?" So it's effectively 35 minutes of no voluntary circulation. I'm here for Sarah's responsiveness. The fact that she reacted as quickly as she did to call 000. The fact that 000 was on to Micah straight away and instructing Sarah to start CPR. The fact that we were 10 minutes away from the Alfred Hospital at 2 o'clock in the morning. But I learnt the pretty awful statistics after the event, and my chance of or anybody's chance of surviving an event like that is 10%. I think the numbers are, Andre.
Yeah, or perhaps even slightly lower.
Yeah, of arriving at hospital alive, and I think you've got another. Of those 10% that arrive, only about half of them, come out of hospital in a reasonably functional state. So, the chain of survival, on that night worked for me. I'm, very lucky. My chest hurt like crazy for 3 months afterwards, but I'm alive. So, Sarah spent 15 minutes. Giving me CPR, and then Micah arrived, and I think they thought she was doing such a good job while they were setting up, they left her to it. And I think, for talking to one of the Micahs following that, I think there was 3 attempts to defibrillate before they got some sort of rhythm back, and whatever unknown quantity of drugs, I think including adrenaline, Andre, if I'm correct, would have been administered. And they managed to get, again, correct me on the terminology, but it's return of circulation, is that the right term?
Return of spontaneous circulation.
I'm close, yeah.
Yep.
After 35 minutes.
So the key there is when the heart's, essentially haywire, there's no cardiac output. So the body's not getting any oxygen, the brain's not getting any oxygen, and so the race is to get electricity to the heart, because when the heart's haywire, a big shock of electricity can put the heart back into a normal rhythm. And the sooner it is from when the heart's gone haywire to when that electricity is given, the better chance there is of resetting it. But in the meantime, the applying CPR or cardiopulmonary resuscitation and heart massage is quite an effective way at getting enough blood flow. It's just a mechanical pump. You're pushing on the chest and squeezing blood around the body, and that can give enough blood flow to keep the brain and organs alive, if you like, until electricity is given. We talk about sort of the golden 4 minutes, which is sort of the downtime if there were no CPR, where there's a good chance of electricity resetting things and there being minimal damage to the body. But that 4 minutes can be prolonged with good CPR. And in Bruce's case, he had very good CPR. The other factor here is that we know from statistics that young, fit, healthy people have better statistics than otherwise. There's something also, I'm almost certain that 8.5, or what we'd call 10 out of 10, was actually extremely helpful in that situation, because one of the things being athletic trains the body to do is to take up oxygen, very avidly, brilliantly. And so athletes can get by on very minimal circulation. We actually see this when we measure them when they sleep. Very little blood pressure is required. And so chances are that your fitness also contributed to the excellent outcome, that you had, thankfully.
That's an interesting comment, because one of the marker ambulances who I was speaking to and still in contact with, after he came to the house, it said when when he arrived, and they obviously they go home unsuccessfully most times. When he arrived and saw that I had shaved legs and was reasonably fit, he said, we might have half a chance here, to himself. Which I thought was an interesting comment.
Yeah. It is remarkable how often, and there was a big study in France where they looked at outcomes of resuscitations across the whole of France, and one of the strongest predictors of good outcome was being young and athletic. There's a few sort of, because sometimes that also means that cardiac arrests are more likely to happen in a sporting venue and areas where there's more likely to have good CPR. But in the setting that like happened with you, I think if there were, I'm almost certain that your fitness has played into into the good outcomes.
I'd like to think so. But, it's interesting, the general population's preconceptions as well. And following the event, I had a few comments from a range of people saying, do you think it was my exercise that caused the problem in the first place? And I think the reality of it is, it was my fitness and my riding that in fact saved me from a situation that was probably going to occur anyway.
Absolutely. It's I don't even know how to tackle that one, but it's one of the most common misconceptions is that I think partly because people being as fit as you were and riding 450 kilometres a week is less than 1% of society. And so people, I think, therefore the default becomes, that's not right, that's weird to do that, and it can't be healthy or something. But every single marker we have, that's not correct. And one of the kind of, if you like, funnier, not funnier, but one of the most quoted examples is Jim Fixx, who wrote The Law of Running, and he sort of was the picture of the fitness revolution in the sort of 70s in America, and then died of a heart attack in I think his mid or late 40s, and in a way gave birth to this whole idea that it's not good for you. What people don't realise about Jim Fixx, or often choose to forget, was that he had a very, very strong family history. He was a heavy smoker, and he'd in fact only been running for a decade or so, and even with that had outlived almost all of his family members. So even one of the most quoted examples is horribly sort of misquoted. I mean, we know that if it could be that if it weren't for the cycling that heart attack could have presented earlier. On the other hand, it could be that if it weren't for the cycling, someone might have thought to think harder about it being heart disease.
And I would have been better off if I was overweight and a chain smoker. I'd have been taken seriously.
I mean, the key here is that it's absolutely true that having a good diet, doing exercise, all of these things reduce your chance of having a heart attack. But there's just no insurance policies. And so whilst all of the public health messages, the Life Be In It ads in the 80s, and they're brilliant, and it's great to encourage the population to exercise more. But I think that in the mindset that became so entrenched that people thought you do those things and you can't have a heart attack. It's all about sort of relative risks, and people should do all the right things, but then at the same time realise that the chances of having a heart attack are not so massive that people have to worry about it on a day-to-day, but if they have new symptoms, it has to be checked out. And I suppose if I went back to just very quickly to that your original presentation where you had the ECG and the blood test at rest, had you had an exercise test, I would be almost certain that that would have led to the right diagnosis and things being fixed. So, if people have symptoms like that, they need to have a more appropriate test to look for heart disease.
I would agree. I was reasonably pain-free when I was not exercising.
Yep.
And maybe my level of fitness and the fact that I as I learned subsequent to the event, my heart had developed a whole range of collaterals, which was supplying blood sort of past where the narrowing was occurring, that obviously were doing a very good job when I wasn't exercising.
Yep. So can you look back on this example and know exactly why it occurred?
Yes and no. So the reason that this occurred was because of what we call ischemic heart disease. Ischemic meaning sort of lack of blood flow to the heart, which is due to these fatty plaques in the arteries, which like a sort of kink in the hose, if you like, just stops the flow getting to the heart. And in that setting, so that's what causes the chest pain when Bruce was riding. And that is also associated with then having a cardiac arrest. Now, where Bruce was unlucky is unlucky to have coronary heart disease, particularly in the absence of much in the way of risk factors, but then also unlucky because even though a cardiac arrest is a potential consequence of heart disease, it's still only a minority of people. So it was unlucky on two accounts. One, for a picture of health to have symptomatic heart disease and chest pain, and then secondly to have a cardiac arrest. So
I got the double whammy.
The double whammy.
Yeah.
But then, fortunately, played against the statistics, as you pointed out very, very nicely, and did extremely well through the arrest.
And again, just right place. Well, sorry, things went against me, but as far as surviving an event like that, everything worked for me. So unlucky but lucky.
Yeah.
Can you talk to us, Bruce, about what happened after? So you're back at home.
Yeah, God, it's all a bit of a blur. Back at home, I had lost 5 or 6 kilograms probably in a week in hospital. I felt as though I'd been hit by a truck. I was sore everywhere, particularly in my chest. My energy levels were pretty low. But I think, I had about a week in hospital in total. And I think on about day 2 or 3, I started walking around the block, which, from being quite active and being able to go and ride for 5 hours, being able to walk a kilometre around the block, was a major event. And I pretty quickly improved from there. I still was in at that point atrial fibrillation, which was, I think, as a result of the event. So, my atrium was beating out of step with the other part of my heart. So, if I test my pulse rate, it felt like Morse code more than anything else. Is that the right description?
That's beautiful. I haven't heard that before. I like it.
But I was, I'd started exercising. I went, 2 weeks of walking to then getting back on my bike, and working up to in fact, because our son was leaving to go to France to ride for a French team, which was on the 9th of January. And he had national championships about 4 days before that, which I attended. And we were getting ready to jump on a plane to go to Europe, less than 6 weeks after my heart attack cardiac arrest. And in fact, the day after, I went into the Epworth to have what they call a cardioversion to try to resolve my atrial fibrillation. So that's basically they anaesthetise you, hit you with a defibrillator, get your heart back to a normal rhythm, send you home again. So, day after having that done, we're on a flight to Europe.
And that was all successful? You walked out of there going,
job done.
Beauty.
Yep, job
tick,
done. Yep,
next.
Survived that event. Get on with life, basically, was I guess my approach at that point. And I don't know how far you want me to keep going, but I started building up again. I was back to 300 plus kilometres a week. We travelled several times back to Europe over the early part of that year, and ended up going back for a 2-month stay from June through to July. So I took a bike with me, so I was out riding around France. We spent time in Italy around Lake Como, and then went to the Italian Alps. And probably was while I was in Italy, climbing some of the hills that I was getting indigestion problems again, and I was still having those problems while I was climbing hills around the Italian Alps. and thought, it's bloody annoying that this indigestion's back again. It can't be heart-related because I was discharged with effectively a clean bill of health from the Alfred Hospital after they'd scanned me and stented me. So again, didn't think, in fact, at that time and even following the discharge from the Alfred, didn't classify myself as being, somebody with coronary artery disease. That happened to other people. So this reoccurring problem that I had, with indigestion was indigestion. I didn't feel too bad. Mentally I was probably not in a, best possible shape. But, I didn't feel as though I had the same, cylinders pulled as I had 6 months previously. So we got back from Europe in July. I had a follow-up, just normal follow-up with my cardiologist in August, mentioned in passing to him this indigestion. He suggested I probably come in and have an angiogram, which is where they put a catheter into your heart with dye and have a look for any further narrowings. So I sort of reluctantly agreed to that, 2 weeks later, and expected it to be a waste of everybody's time, to be honest. So I still remember, so when they give you these angiograms, you're still conscious. They give you a mild, bit of pain relief. And, I expected it to be all over and done within about 5 minutes and off you go, thank you very much, you're all good. And probably about halfway through the procedure, I'm thinking this is not sounding like I thought it was going to sound. It's not sounding overly positive, just sort of the murmurings between the cardiologist and the nurse and the technician. So they removed the catheter, wheeled me out, and, my cardiologist came and spoke to me afterwards and was suggesting that I might want to talk to a cardiac thoracic surgeon. I thought, well, this is interesting. Why do I need a surgeon? But as it transpired, I'd had, in the course of 8 months by that stage, it probably would have been significant further disease developed in what they call my proximal LAD, which is your left anterior descending artery, which is what I think Andre commonly called the widowmaker. Is that the right terminology for it?
Yeah, so it's sort of the artery that runs down the front of the heart and supplies the biggest amount of territory. So it's the number one in terms of our concerns.
Yeah. So I had an 80 to 90% narrowing of that coronary artery and another narrowing of a less major artery on the right-hand side of my heart. So I was not allowed to go home. Go straight to jail, do not pass go. And was in the cath lab the following day having additional stents in the proximal LAD, which was, I think, from what I understand, a tricky procedure because they had to manoeuvre around the previous stent that was there following my initial heart attack, which was why it was thought that it may not be resolvable with stents, and I may need to have a bypass. Fortunately, it all worked, and I was out of hospital 4 days later. So that was probably, that was a shock, to be honest. And I think a turning point as far as me accepting at that stage, probably like the alcoholic, saying that you need to admit you won before you can go into recovery. That I had heart disease, and I haven't changed much of what I do, but now very much accepting the fact that I do have coronary artery disease, and it's something that I now continue to have to manage. And I think following the first event, I just felt it was a one-off, won't happen again. Just get on with it. Nominally, as you said.
Yeah, there's a number of things there, because I think it's a natural human reaction as well to one, even when something really significant has happened, is almost a little bit of denial sort of coming through. What is also interesting is from the cardiologist perspective, because whilst I pointed out beforehand we're not very good at predicting the person who's going to have a heart attack, what we do know is the person who has had a heart attack or who has heart disease are in the highest risk category. And so, when Bruce came back from Europe saying, I get this chest pain, the cardiologist has basically gone straight to the biggest test, like bypass doing a stress test or any of that, because in his mind, he said Bruce is at the highest risk and he's got chest pain. He needs an angiogram, which is exactly the right thing to do. And so although Bruce was saying, I'm going in and I've got 5 minutes and this will all be normal, the cardiologist would have been thinking quite differently to that. And the other thing that's, for people who are listening to this podcast who have heart disease or who have had a heart attack, there's a lot of sort of pros and cons and a lot of public opinion about some of the medications that we use to prevent a heart attack. The most common and effective one we have being statin medications. And perhaps in the past, sometimes they were overused for primary prevention or preventing heart attacks before they happen. In people who have had a heart attack, they are one of the most important medications we have. And we're always impressing upon people that that there's very, very good reasons for being on medications like this. And again, it's not like you stop the medications and you're going to have a heart attack, or if you're on the medications you definitely won't have a heart attack. It's all reducing your risk, and they reduce your risk about 30%. But these are the sort of things that we can do once people have had a heart attack that make a difference. And then even with the best possible sort of medications, there's still the chance of recurrence and hence being alert to the symptoms, both the patient and also the doctor. And so that again was a difficult experience, but a good call and good management.
Yeah, and my 2 attempts at self-diagnosis today have been pretty bad. And I was saying to Alex when we were coming here that I'm now trying to work out what's normal and what's abnormal. I still have strange sensations. But I've had more recent stress echocardiograms done, which are all clear. Yep. So I'm still trying to work out in my head now, what's a normal chest pain, and what's a chest pain that I need to be aware of and should have followed up.
Yep.
So I'm probably overly cautious now.
Which is not a bad thing. I think as cardiologists, particularly in people that have had a heart attack, where we should be very sensitive to people coming in and saying, I've had this twitch and I'm worried about it. And it's our job to work that out and reassure. And I'd much rather my patients be jumping at shadows in a way, to a degree. And then quite typically, just as you're describing, people become more and more aware of the things that they can quite safely ignore. But often that comes with just some false alarms and reassurance, which is part of our job.
Yeah.
How do you reflect on the last 2 years now, looking back at the way you approached it, managed it? I
think following the event and the best way I can describe it, it's a bit like doing the Control-Alt-Delete on your computer. It just cleared a whole heap of crap. That your ability, anyway, it just put life back into perspective, with phenomenal clarity, so you clear all the junk out of the files, and, I felt, I went through a period of just elation, with phenomenal clarity of thought. that I assume most people have following events like that. That sort of followed into a period of I wouldn't call depression, but period where I went through, which was part of the period while we were away, and I think my developing heart disease at the time probably had an impact on my mental health to some extent, and that was interesting. Following having the additional stents, September last year, that immediately improved my mental health, and I was feeling far better and more positive again. So this whole correlation, which I think is also a very interesting one between head and heart, is, I don't know how scientifically proven it is, but I just the way that my perspective changed immediately following that was extraordinary. And I think for all of us, the whole family that's been involved in the process, look, I think there's been an element of, I think you'd call it post-traumatic stress, but, I think more so it's been sort of post-traumatic development. It's been, it's bizarre to say, but in some ways it's been, it has been enlightening, and it has been, a difficult experience, but, I think we've come out of it the other side, better people.
I'm going to sort of tread carefully here because, I can, at various times when you've spoken, it's... I
still get a bit emotional about it. I'm not sure whether you're picking that up. But
well, absolutely, and I reckon that's completely understandable, and it must be, again, strange because you look absolutely the picture of health, and you are the picture of health, but people would find it hard to believe what's happened. One of the things that is difficult in raising awareness of these problems from a cardiologist perspective is that there's not really. I think it's hard for people to fully empathise or to understand the gravity of what's happened, and that's true sort of for survivors, because I'm sure when if you're at a dinner party or something and you mention it, people wouldn't just not even know where to start to believe or grapple with things. But similarly, had things gone differently, I think it's really challenging because heart attacks and if we were to create the stereotypical type of situation, it would be the middle-aged male, and you're living an extremely successful life. Your son's about to go off and compete, and you're training with him. Everything's going well, and the thing that I sort of sometimes think about, it'd be going off to work one day and kind of not coming home. And you've sort of faced that, and now you're on the other side. And when you mentioned before about Kerry Packer's kind of there's nothing there.
Yeah, I won't use the expletive because...
yeah. But now, how much does that ever consume your thoughts? Like how, does that create a sense of sort of fear or more of determination?
No, I don't live in fear. I live with the knowledge, that look, I could have another event, but I'm not fearful of it. It does put, once you've had an event like that, it does put your mortality and death into perspective. But death, after doing it, sort of having a go at it once, doesn't concern me,
right?
Which it might be a strange way to look at it. I'm far more accepting and relaxed about it, and if fortunately, I'm still alive 2 years later, but I do face the prospect, that I could have another event, but it doesn't affect me. It doesn't affect me day by day. It's something that sits in the back of my mind, but you know, it doesn't prevent me from doing anything.
Yep. I just want to clarify as well, because what you know, with the right medication and awareness, we'd be expecting you to live a good, healthy, long life now.
Yeah.
But it's more just as you said. I think that very few people get to
have this perspective.
Have this perspective, and I think it's a very varied response. You know, some people are left with a sense of fear, and I find it really impressive the way you've approached things afterwards.
Yeah, probably the you know, and you know, the most, in some ways, the most traumatic part of it for me is not what happened to me. It is, you know, the trauma, you know, that Sarah went through on that day. You know, Mackie was at home at the time as well. You know, 1 o'clock in the morning. You know, you're woken up to that sort of commotion. You know, your husband, you know, your father's, you know, unconscious on the floor. You know, that's,
yeah.
You know, that you know, I'm talking about it now. I mean, that's you know, what I get emotional about.
Yeah.
You know, and that, you know, and you put yourself in their shoes, and you know, I'm 2 days in ICU. You know, nobody's providing any assurance of what my state of health is going to be when they bring me out of that induced coma. You know, so there's days of uncertainty. You know, there's that initial trauma of that night or the event. You know, and there's just days of unknown that you're having to live with and manage. And you know, you know, that's what that's what makes me so emotional. You know, what happened to me still feels as though it happened to somebody else. You know, it's not. You know, it's weird. It's sort of, you know, almost like an out of body experience in some ways.
Yep.
But you know, I you know, and I'm happy to do things like this to help educate more, to save you know, other families from the same event and trauma. You know, I came out of it the right side, but you know, the amount of trauma would have been even more extreme, you know, if I hadn't survived the event.
Yep. In a way, just quickly, I can't. I really think everyone would be very grateful because the other thing is that I find that once people in your situation, it's not necessarily the norm to then go and be an advocate and to share that experience because it is, you know, somewhat traumatic and people don't necessarily want to relive that. But it's really beneficial for people to hear this and to you know, you're an inspiration, even though it was by no means deliberate.
Yeah, no, reluctant.
A reluctant inspiration.
Yeah, reluctant inspiration. Look, to me, you know, talking about it, you know, I do find bits of it still hard 2 years later. But, you know, to me it's quite normal to try to communicate, you know, that event. And, you know, with the hope that, you know, things like this will help, you know, communicate the fact that, you know, normal people are at risk.
Yep.
You know, don't ignore the obvious signs. You know, get it checked out.
I suppose that also comes to because people will be listening to this and saying, "Oh, geez, I don't want that to happen to me. How can I be sure that I won't have a heart attack?" And a number of the things that have come up in the conversation are brilliant examples of exactly how that works. And the first is that people who have a cardiac arrest, about half of those people will have had symptoms leading up to the event. So just as happened to yourself, although unfortunately weren't picked up, but you know, the first and most important message is if people do have feel like they've lost 2 gears whilst they're cycling, or have indigestion, or really sometimes we say any pain from the knees to the top of the head, particularly when it occurs with exercise, you need to get that checked out. That leaves another 50% of people who will have a heart attack who have no symptoms and have no idea. And that's the really tough nut for us to crack, is to try to predict those people who are at risk of having a heart attack when they have no symptoms. And the ways that we can do that are firstly to check out people's risk factors. So to get people's blood pressure measured and their cholesterol, to know about their family history and whether they've smoked or have diabetes, for example. Perhaps some of the people listening to that mightn't fall so much into the latter categories, but definitely even people who 25, 30 years onwards, you should be having your blood pressure and cholesterol checked infrequently, every 5 years, unless there's a problem, to get some idea on what that risk is. That helps us put people into a low, medium, or high risk category, and then we can, then there's some preventive therapies or further investigations that might happen. The truth is, though, that we're moderately good at that at best in terms of predicting the person standing on the tram who's going to have a heart attack. The cardiologist is only going to be moderately good at that process. There are some new kids on the block in terms of trying to identify risk. One that's getting a lot of publicity is what we call a coronary artery calcium score, where we do a quick scan and look at whether there's any bony deposits in the arteries of the heart. And that is another way of predicting someone's risk. It's still definitely not binary. We can't say your coronary calcium score is this, you will have a heart attack, or it is 0 and you will not have but it does help us, if you like, sharpen the pencil. But that also is not a yes-no thing. I would not be recommending that everyone goes out and has a coronary artery calcium score. The best advice we have at the moment would be to get things done like your blood pressure and cholesterol, and if that puts you into a moderate or higher category, then we would talk to people about the pros and cons of a calcium score, because at the end of that calcium score, all that we really have, which is still helpful, is lifestyle advice, use of some medications like statin medications to reduce the risk of having a heart attack. And then the other thing that is really key, again, coming back to it, is the feelings of symptoms, and particularly if they're new onset, they really need to be checked out.
What about the research that's happening in this space? Where is the direction for that?
So it's a bit of a holy grail, because perhaps I didn't say at the beginning, but coronary heart disease or fatty deposits in the artery is the number one killer of males, and the number 1 or 2 killer of females around the world and in Australia. And being able to pick the person who's going to have a heart attack would be one of the great discoveries of medicine. And at the moment, as I said, those sort of measure blood pressure and cholesterol give us some idea, but it's far from perfect. So some of the things that we're doing for research are things like genetic tests because we know that family history is a risk, which gives us a bit of an insight into genetics. But there's now tests you can do where you do a genetic risk score, where it takes all of your genes and uses sort of a mathematical algorithm, which again can sort of sharpen the pencil, so you're at greater or lesser risk. It's still not perfect. Things like the coronary calcium score and advanced imaging, all of these things with the hope that we'll be able to more accurately identify people who are going to have a heart attack. Then also in terms of research, because already some of the things that have occurred over the last decade or so have been significant steps forward. So, for example, Bruce was saying that he was in intensive care for 2 to 3 days in an induced coma. the reason they do that is they cool the body, because we know that in cooling the body, the better the chance the brain has of recovering, and that's now standard of care. And the research that led to that actually came from some investigators in Melbourne. So each of these, if you like, incremental discoveries can in themselves save lives. So our job, and the reason that we're involved in this research, is that we have a big problem, which is heart disease. It's common. It affects people that where it's, if you like, unfair. It's not right that Bruce, doing everything right, should have a heart attack. And to be able to get better at predicting, and to be able to better treat and look after the consequences. Things like having more availability of defibrillators, having them in the right spot. There's some clever apps now, Good Samaritan apps, where people who can do resuscitate CPR can put their name on an app, and if an arrest happens, you get an alert on your phone and you run to the spot. All of these intersections between technology. There's a group in Canada that are using drones to fly defibrillators into spots where there's an arrest. I mean, each one of these things might prove successful in reducing making an impact on the problem. I've actually got more faith in a whole lot of those little discoveries making cumulatively a big impact, rather than there being a magic bullet, where we find one discovery that solves the whole problem. I'm not saying we shouldn't try, but that seems a little bit simplistic for a big problem to me.
I'm not sure whether Sarah would put her name up as being a potential resuscitator for the app. I think once is enough.
Hawthorne East covered.
Yeah. But I think the other thing that perhaps could be mentioned is that Bruce has also financially been a big supporter to help people in a similar situation, and a huge thanks from that perspective as well, because it is the problem is I am a researcher, so I believe in research. I believe that the advance in medical care comes through looking for new discoveries. And I'm really quite confident that, as I said, 20 years ago, it may be that Bruce's outcome would be different. And in another 20 years, it may be that Bruce's heart attack wouldn't have happened at all. And they're the kind of advances where when you've got a face in front of you where you see the impact of the research, it's really that's why we do it.
And that's why we support it. We're looking forward to seeing where that research goes, and strong believers in supporting cardiac research and education. There's got to be some good that comes out of these sort of events, and as I said, I think it has very much changed our perspective on life and the world, and we've got so much out of putting back in a whole range of different ways. Bad things can provide a lot of positive benefits in the long term.
Well, thanks for sharing your story, Bruce, and thanks for your support. Thanks, Andre, as always, and thanks for listening.
Thanks, Alex.
Thank you.